know when to start.
Yes, sir, we can start.
Okay. So very good evening, one and all. I am Dr. Ketan Kulkarni from the medical services team at MK Pharmaceuticals. Along with me is my colleague Dr. Sridevi Gundu. A very warm welcome to all of you, and warm welcome to our faculty for today, Dr. Pradeep sir, who is the Chief Medical Officer at YRG Care at Chennai. Along with him is Dr. Rifa Khan, who is the clinical epidemiologist at YRG Care Chennai. So, welcome to the webinar on uh, HIV. There are two topics today. One is a new era and our long-acting ART treatments, the future, and oral PrEP, an opportunity to improve. So the first topic for today will be presented by Dr. Pradeep, and the second topic will be presented by Dr. Rifa Khan. So the audience is there, and later after the two esteemed speakers speak, we'll have a question and answer session. So to introduce Dr. Ambrose Pradeep, who is the Chief Medical Officer at YRG Medical Care Center in Chennai. So he oversees all clinical services, including clinical research at YRG Medical Care, which is an NGO that has been primarily worked in the field of infectious diseases and has been a forefront of many disease outbreaks, including COVID-19. And he's a active researcher in the field of HIV medicine. He was a Fogarty International Clinical Research Fellow at Brown University, USA. He is experienced in the field of HIV medicine, acute and critical care medicine over the past 15 years and attends to all inpatients in YRG Care Network hospitals. He has been the principal investigator on record for all US NIH network trials at YRG Care and served as an investigator in the Hepatitis Transformative Science Group at NIH between 2021 and 24. He is currently serves as investigator in the prestigious antiretroviral therapy strategies transformative science group. He is a recipient of multiple awards nationally and internationally. His main aim is to make quality medical care affordable and accessible to all, especially the hard to reach and vulnerable populations in the community. And his keen interests are the HIV, HCV co-infections, HIV induced neurocognitive disorders, including HIV immunology. So thank you, Dr. Ambrose, Sir, Dr. Pradeep, for today's webinar. Our
So,
next speaker for today, yes.
yeah, so you want to introduce the next speaker or should I go ahead?
Sir, I'll introduce the next speaker so that
Yeah.
the introduction will be finished. Okay. And then I'll give it to you, sir. The next speaker is Dr. Rifa Khan, who is a clinical epidemiologist, nearly a decade of experience in clinical trials, uh, and 7 years experience in infectious diseases and public health research, focusing on key populations across 15 cities in India. She has completed her undergraduate degree in medicine, post-graduation in public health for development, and professional certificate in pharmacoepidemiology and pharmacovigilance. She has navigated the requirement of academia, industry, and global health. And as a physician, she has served the people living with HIV and high-risk populations in India. She is actively involved in training junior researchers and clinical research teams and experienced in navigating the health infrastructure and outbreaks in India, including strategic purchasing, funding, and financial mechanisms. So over here, uh, I would like to invite Dr. Pradeep sir for his session. Over to you, sir.
Uh, Thank you very much, Dr. Ketan, for that kind introduction. I will just start sharing my slides and I'll just request you to confirm if it's visible. Okay, is there audio? Share. Are my slides visible?
Yes, sir. They are
Yes,
visible.
sir.
Yes,
Yes, sir.
and it's moving as well, right?
yes, sir.
Yes.
Okay, thank you very much, and good evening to everybody for joining the webinar. I'm Dr. Pradeep, and thank you for the very kind introduction. This is something that is always talked about. I think it's quite an important topic, and at least the need of the hour, because people generally think that injections are better or superior to tablets also, right? So that's the general thing with which is ingrained in our patients' minds as well. And ever since there have been news and articles about new medications and new injectables, and over the last 2 years, we've actually had quite a lot of patients thinking that these are cure actually, and they've been desperately looking forward to it. And I also can remember some of the patients selling some of their properties to be ready and equipped to purchase these medicines when they come out actually. So this that's one of the reason why I've taken this topic. And um, in today's presentation, we will be going through the HIV landscape, how it has transformed, not too much as maybe a slide. Why do we need a long-acting ART? Do we need it at all? And a little bit about the early injectables that have been approved and used, and the currently approved long-acting antiretroviral therapies, and the long-acting antiretroviral therapies in the pipeline. So we are Biologic Air, and we are located at behind Pacheppas College and in Chennai, and this is our facility, the Suniti Solomon Center, and it's like a one-stop shop for HIV care and ID care. So I do not know how many of you know the picture in the left. The picture in the left was published in the Life magazine way back in 1990. It's a picture of a dying HIV patient. The patient is one that of David Kirby, and he was one of those initial activists and initial person living with HIV who died of HIV and its complications. And this was published way back in the 1990. Around that time, we all know that there were no effective treatment, and invariably HIV was a death sentence. Soon we had drugs, and we had to combine multiple regimens, and then we had the highly active antiretroviral therapy. And in the early 90s, what happened? You had like the pill burden. You had almost 20 pills which are being consumed different time of the day. Those pills came with its own set of side effects. So you had pills that were taken to control HIV. Then you also had to give pills to manage the side effects which the other pills that are being given for HIV was causing. And today, what we have is a single pill, which I feel is very, very good, very effective, very safe and tolerable. And that's what ART has simplified to now. And how has it impacted, and what is the impact on the long run? Gradually, we have seen people doing better over years, and they've been gradually gaining up. And currently, some of the data that we are looking at shows that people with HIV live as long as people without HIV. uh, or sometimes some data shows even longer, some of the data from the European study. So having said this, what are the gaps that we have? So when we look at UNAIDS targets, we have the 90-90-90, which has been transformed to 95-95-95 by 2025, and we are far from achieving it. So basically what it is you want at least 95 people diagnosed with HIV, 95% of people linked to care, and 95% of people who have their viral load suppressed. So is that really happening? On the ground reality, we are far from it. So if you look at the US continuum that is on the right side showing what is the thing, you can see a large drop off between the people who are diagnosed and people who are linked to care and people who are retained in care, and finally the people who are virally suppressed. So what is constantly happening is you have this pool of people who are at a risk of HIV transmission, and which is actually not good if you're looking at preventive efforts in mitigating the disease transmission. So when we look at how these gaps and how to move about, One of the biggest challenges adherence. When we look at people, one of the biggest issue that people have is adhering to medications. So what we generally feel, or what we feel overall as researchers, is when we look at ART versus injectables, injectables are definitely going to have a better adherence. So it's going to make a big difference in people, especially who have multiple travels. People who, as they grow older, we are seeing an older population as well. They have a what we call as polypharmacy, where they have to take medications for multiple drugs. So you have then the hard to reach and vulnerable populations, especially the people who inject drugs and migrant workers and truckers. Sometimes people feel comfortable not having to take their pills daily, instead just take an injection over a period of time. Then you have people with mental health issues. There again, injectables will definitely be superior. It offers anybody a chance for better privacy, and that way they have reduced stigma. One big advantage is we can achieve 100% adherence. So even generally when you see in your clinic, though you have your patients who have suppressed viral load, what we generally see is people are not 100% adherent. They eventually miss one or two pills a week. So when you calculate the overall adherence over a month, most of them have it only around 80, 85 to 90 percentage. And that is actually enough to suppress their viral load, because the current ART is very potent. But what it does not do is, it still have their inflammatory markers a little higher than normal. So you will have people who are virologically suppressed, but when you compare it with people who have 100% adherence, there are definitely changes in inflammatory markers, especially interleukin 6 and D dimers. So these are things that can definitely be mitigated by having a long-acting ART. Doesn't necessarily have to be an injectable. So we'll come to that. So, so I will now proceed to some of the ARTs which have been approved, and long-acting ARTs, and we will look into that part of it. And when going forward, how I've structured this topic is we are looking at long-acting ARTs from a point of treatment. So I have not talking about prevention using these long-acting ARTs, because it's a separate topic in itself. So when you look at the first long-acting ART which was approved, it was a drug called ibalizumab. Okay, it's a monoclonal antibody against CD4. It help prevent entry into the cell. And this was approved as way back at 2018 for treatment of HIV experienced people with MDR HIV. When we talk about multi-drug resistant MDR HIV as a salvage therapy, it was given as an IV infusion, and those infusions were given every 2 weeks. This, like the name suggests, it was a salvage therapy. It was like a stopgap for people who have exhausted all medications, and it was not majorly a viable option as well. So it didn't actually make, no surprises, it did not make into India shores. It's not easy to make monoclonal antibodies and store it and be able to supply it as well, especially when it was not something that could be expandable on a larger scale. So when we look at the current FDA approved long-acting antiretroviral therapy, following the first one I showed you, ibalizumab, the next one was not until 3 years after. Okay, it was a drug called cabotegravir and rilpivirine, and it was approved in Jan 2021, and it was approved for people who are on regular ART and who are suppressed virologically, and it has an option of being given on a monthly basis or every 2 months. The next drug was same cabotegravir, which was approved for PrEP in 2021. Then this wonder drug called lenacapavir, which everybody is talking about now. And it was approved for heavily treatment experienced MDR HIV. That's the first drug for MDR HIV that has been approved after ibalizumab. And it was approved in December 2022. And finally, in June 2025, uh, lenacapavir was approved for PrEP, for PrEP use, for HIV prevention. So we'll not get into that, but that's kind of changed everything for HIV as far as prevention is concerned. So now going forward, I will go over each of the medication, cabotegravir and rilpivirine and lenacapavir, to see how things went on and what kind of got their approvals done. The first trial that looked at cabotegravir and lenacapavir was this trial called the Latte study. So basically what Latte did was it compared actually not an injectable CAB rilpivirine, but a daily CAB rilpivirine as a dual therapy versus a two-drug triple therapy with efavirenz based. And basically, this was a dosage study and it was a phase 2 study. And it was done in people who were treatment naive and virologically suppressed. So they had an induction for about 24 weeks, followed by treatment for 96 weeks. And it showed that these medications were not non-inferior to triple drug therapy. So 3 doses were done in the trial, a cabotegravir of 10 milligram, a cabotegravir of 30 milligram, and a cabotegravir of 60 milligram. If you look at the graph, all three actually work as well as people taking triple efavirenz-based regimen. But the company chose to go with 30 milligram cabotegravir. We continue to do the 30 milligram cabotegravir till date. After the latte study, first latte, came the latte 2. The latte 2 was basically a phase 2B open label multi-center randomized maintenance study. And it had a 20-week oral induction followed by with cabotegravir and abacavir 3TC, followed by a long-acting cabotegravir and rilpivirine. And it was given either for 4 weeks or 8 weeks. And what it showed was, it showed excellent viral suppression between both 4 weeks of CAB rilpivirine as well as 8 weeks of CAB rilpivirine. And when compared to CAB abacavir 3TC, they all did very well. And the study was non-inferior. And the durability was further extended from 96 weeks, was further extended through 5 years to see how people tolerated the medication. And they found that the tolerability and the safety and the viral suppression was very good even through 5 years. So this was the first time also that an injectable was used. And whatever the side effects, interestingly, the adverse events, though the viral suppression and the tolerability was good. Generally, but when you looked at the adverse events, there were slightly higher adverse events in injectable versus oral. So the common side effects like pyrexia, nausea, headache, dyspepsia, they were slightly higher. But the most worrisome thing was the injection site reaction. 97% of people complained of a lot of pain. 30% had some nodule, swelling, pruritus. So these were some of the common symptoms, and this was one of the reasons that when we look at injectable, quite a lot. Every time people talk about is ISR, which is injection site reactions, and these are basically what we are worried about as well. But they don't cause serious events, but enough to maybe people not want to take these injections on the long run. So subsequent to the latte study was a larger group of a flare study. And this flare study basically showed that, so now that we've done that, now this study was basically looking at comparing with the standard triple drug therapy. The previous study actually did cabotegravir with abacavir 3TC, which is again not the standard of care most of the places. This study basically looked at dolutegravir, abacavir, and 3TC. Initially, people were chosen who were ART naive with a high viral load and who are hepatitis B negative, because these drugs don't cover hepatitis B. And what happened was people were given treatment with 2 arms. One is oral; they were given an oral lead-in with CAB rilpivirine, followed by an injectable CAB rilpivirine with every 4 weeks. And they found that they had similar rates of virological suppression. And subsequently, both the arms were merged into having an extension of CAB rilpivirine arm as a single thing. Both of them have a success rate of 93.6%, whereas dolutegravir has a success rate of 93.4%. So it was non-inferior. And interestingly, our future trials, which especially the Atlas and Atlas M2, which is again looking at similar design structures, showed pretty much great virological success. Basically, these were the studies which kind of showed us that these medications were good enough and they work very well. And but the flare also had some treatment failures because it had slightly higher numbers which were enrolled into the study. And there were a total of 7 failures, and six failures. 3 were with the dolutegravir, abacavir, and 3TC arm, and 3 were actually in the long-acting cabotegravir and rilpivirine arm. And when we looked at it, uh, pre-existing rilpivirine resistance associated mutations, if they had it in the baseline, they would be a likelihood chance of failing this regimen. The other thing that also had was HIV-1 subtype A6 and A1. They had a slightly higher chances. And people with higher BMI of more than 30. Because what they found was consistently plasma cabotegravir concentration and rilpivirine concentration was much below, especially in people who failed these regimens. So, and they found that people with a higher BMI, the chances of these uh, what do you call there being a suboptimal drug threshold, which can cause regimen to fail and develop resistance. So subsequently, finally, what happened was, the approvals came through, and we wanted to make sure that how to escalate it into the community and where do we place it. Though the governments, I mean, like FDA said you can use it safely across people who are virologically suppressed. The Latitude study, this was a study which was like a phase, it was a study which was done through the AIDS Clinical Trial Group Network, which is under NIH. And this basically looked at people who were non-adherent to HIV. So basically, they picked up people who were not taking their medications, who were very irregular, and what they did was they kind of gave them an intense, continued the standard of care arm for the initial 24 weeks. And they incentivized in a big way. One incentive was every time they completed their visit, they were given an incentive of $75. If they had a virological decline, they were given another incentive. So they were heavily incentivized, continuing their earlier standard of care. And at week 24, they either switch them to cabotegravir and rilpivirine every 4 weeks versus the standard of care. What they found was during the primary endpoint at 72 weeks, they found that people who are on long-acting injectables had a better virological suppression compared with oral standard of care therapy. And subsequently, what they did was they converted everybody into injectable. But looking through some of the data that came, the interim analysis by the Data Safety and Monitoring Board by 2024, they found that these injectable arms were much superior. And the DSMB said that they wanted everybody to be shifted over to long-acting injectable arm. So basically, we have seen a overall superiority in maintaining viral suppression with cabotegravir rilpivirine. Just to summarize this, so it's basically a very well proven switch therapy, not an option for initializing therapy, and you can't initialize without having a baseline resistance done. And an option for people who can't take daily ART. It requires injectables every 2 months or a monthly injection. One issue is the injection site reaction. The risk of treatment failure is higher even with one-time injection. So we need to be careful. And one thing is it doesn't treat hepatitis B. So we need to make sure that people are evaluated for hepatitis B before we can start them on this therapy. One issue that we also have with cabotegravir rilpivirine is a little expensive and it's hard to produce. So far, it is not recommended in pregnancy as well. So this is about the cabotegravir rilpivirine. The next is lenacapavir. Okay, this is like the magical drug that everybody talks about now. So it was a first-in-class capsid inhibitor, which is a new class altogether, and it has multiple mechanism of action. So basically, the capsid is the part of the HIV virus. It's also called the HIV core. So basically, it has all the. Imagine that you want to gift pack something and you want to put in all the goodies. So it's something like that. So the HIV core pretty much has all the genetic material, the RNA, the reverse transcriptase, and everything. So it's made up of a hexamer and a pentamer joined together to form this core structure. This core has to actually get through into our cell and get through into the through the nuclear pore complexes into the nucleolus, and then where into the nucleus, sorry, and where it gets attached to integrated into our DNA. So how lenacapavir works is it blocks nuclear transport for the uh, core to get in. It has to be a little bit more flexible, so it makes it very rigid, so it's not able to enter into the cell effectively. It not only works there, it also works at the virus assembly and capsid assembly, which is also a crucial integral step in formation of this hexamer that is essential for this capsid assembly. So this was approved in 2022 for heavily treated MDR HIV. It has an option to be taken daily or weekly, and it has also long-acting subcutaneous injections, which can be given every 6 months. So the first study which looked at lenacapavir was the study called the Capella study. Okay, the Capella study was people who were randomized into two cohorts. You had cohorts of people who were not who were failing therapy, who were not though they were taking their medications, they actually had no effective antiretroviral therapy. So they were given, one group was given lenacapavir. The second cohort with people who were on regular medication, who had their viral load controlled. So in that group, both were given oral lenacapavir initially for a period of 15 days, including a placebo control group in the cohort one. And basically what it showed was in 2 weeks time, where you see at a primary endpoint, both people who had failing therapy and where lenacapavir was like a monotherapy versus oral lenacapavir, which is OBT, they basically showed that there was, especially in the first group where there were high viral loads, people had 2 log decline, which was kind of unheard of being a monotherapy drug. So subsequently, what happened was people were followed up every 6 months with what they mean by OBT is optimized background therapy, where you do a genotyping and see what works, what doesn't work, at least have one active agent. And this kind of changed everything. And this basically was the reason why lenacapavir was approved for treatment of heavily experienced patients. Subsequently, what happened was there was a study called the Calibrate study, which was basically a study which was looking at the dosing of lenacapavir and the backbone usage of lenacapavir across various groups. So there were 4 groups which was chosen in this. These were all ART naive, and group one received lenacapavir along with oral emtricitabine, and it was switched to daily TAF, to oral emtricitabine and TAF initially for 26 weeks, and that and then switched to daily oral TAF and continued on as a dual therapy. The second group had lenacapavir subcutaneously given every 26 weeks. I'm sorry, every 26 weeks, and then oral emtricitabine, which was TAF, which was switched, and then the later half was switched to a bictegravir, a INSTI. And finally, group 3 was oral lenacapavir daily with oral emtricitabine and TAF. And group 4 was the standard of care with daily oral bictegravir, emtricitabine, and TAF. And they were followed, their primary endpoint was at 28 weeks, and then they were followed up for a period of 54, followed up by 90. These studies were published in Lancet, and basically close to 250 people were enrolled into the study, and they were randomized equally into 4 different groups. And basically, when you see, they had more or less similar efficacy. Group 1 had 90% of people who were suppressed. Group 2 had 85, Group 3 had 85%, and Group 4 had a 92%. The drug was well tolerated, and then the minor side effects, which included headache and nausea, which was minor enough. And they had some injection site reaction, though these were subcutaneous injections, and erythema, swelling, and pain. These were the commonly experienced side effects, and they were generally mild or moderate. And there were no serious adverse events related to the study. So this was the Calibrate study. So basically, what we have with lenacapavir is a wonderful drug where we have 6 months of therapy, but We don't have an optimal background therapy where you can say, okay, I'm going to give you 6 months of another drug, so you don't have to come and see me. So your other backbone eventually will have to be an oral drug with tenofovir, emtricitabine, or abacavir, lamivudine, or it's going to be cabotegravir with cabotegravir as a plain or cabotegravir with rilpivirine, but with given at different time points. So it still has logistical challenges that comes with it. So when we look at generally a future of long-acting ART after looking at this, so what we have is, like I said, one long-acting injectable where all the drugs are given as a 6 monthly injectable. Lenacapavir we have already talked about. Teropavimab and zilrivimab, they are called as TAB and ZAB. So basically the regimen is called Len, TAB, ZAB. The TAB and ZAB are broadly neutralizing antibodies against HIV-1 and all are administered as injectable. Lenacapavir is given as a subcutaneous injection, whereas TAB and ZAB is given as IV infusions. But the problem is you need to look at susceptibility of TAB and ZAB before being able to give these neutralizing antibodies, which is a challenge. So the preliminary data was presented in CROI 2025. So 53 people were enrolled in the intervention arm, and basically and they were compared with the standard bictegravir, tenofovir alafenamide, and emtricitabine, and they basically looked at viral suppression at week 26, and 96% maintained viral suppression. They were well tolerated, and this is actually moving into phase 3. I do not know how BNB or broadly neutralizing antibodies are going to be scalable in the Indian context. The next is the drug called islatravir. Okay, so this before lenacapavir, this drug gained a lot of attention. This was a new class drug called nucleoside transcriptase translocation inhibitor. And one thing it had was it was similar to NRTIs, and but it had activity against most of the NRTI resistance mutation. The most common is that we see is M184. And this was a drug which was being evaluated for a long-acting 6-month or even implants where you can do 1 year yearly implants, and basically showed that it worked very well. But the biggest issue was it was causing lymphocytopenia. And the reason why it was causing lymphocytopenia, initially it was thought that it was causing mitochondrial toxicity. Thankfully, it doesn't cause mitochondrial toxicity. What it does is the islatravir triphosphate, which is the active metabolite, has a higher half-life and it gets accumulated in the lymphocytes, and which was the reason why it was causing that lymphocytopenia. So subsequently, there was people kind of lost interest in this, but there were trials which were done looking at low dose islatravir, and the low dose islatravir seems to be working as well as the higher doses. And there has been an NDA which has been submitted for islatravir doravirine as a single pill combination once daily, and this is expected to have approval by 2026. The interest in islatravir is now going from a daily tablet to a weekly tablet, and it's now being the weekly tablets are being now studied with lenacapavir and a new NNRTA called ulinovirin, which is by Merck. It's MK8507, and these are both done as a weekly tablet, and those will still be better than having to take daily medications, right? So the islatravir once weekly was presented recently, and what it shows was it was non-inferior, and when compared to the standard Pictavi, and people with islatravir had similar. It was a non-inferior study. It continues to be non-inferior, so which is good. Following this study, we have 2 more phase 3 studies with bictegravir and with islatravir and lenacapavir, and so Island 1 and Island 2. So both are enrolling now, and we should have results of this probably in the next 6 months. We should have more results to see if this is viable. And I feel this is a good option even for people here in India, where instead of worrying about injections, You can have one pill which you can take once a week instead of actually having to swallow daily pill. Like, you go to church every Sunday or you go to temple every day or something like that. You can build it to your routine on a weekly basis, and it might work very well. So the other new molecule that I would like to tell you is one is called, these don't have names, as you see, we have numbers. So the VH184, which is a third generation INSTI, and it is basically active against viruses with mutations against dolutegravir and cabotegravir, and it's basically showing good safety and tolerability, and they are planning to have potential long-acting formulations in the future, and this will be good to have, especially in a world where there is a chance of dolutegravir failure, and that still happens. It's good to have backups and alternatives. The next drug is a capsid inhibitor, VH499, and this was again developed recently, and it again has excellent antiviral activity, and they are again planning for long-acting injectables in this thing. And there is another drug called the ultra long-acting cabotegravir. Cabotegravir right now is being given on a monthly basis or every 2 months. The ultra long-acting was given every 4 months. But the problem with ultra long-acting was there was very high injection site reactions, and this had to be discontinued. The molecule has then hence been remodified, and this ultra long-acting cabotegravir is going into phase 1 right now. We'll have to wait and see what comes of it, but this is phase 1. So I haven't gone into many phase 1 drugs. These are the drugs which have basically shown some potential interest. And basically, to summarize, injections are not like a one-stop shop that we think it is going to be. It comes with a lot of logistical challenges. The biggest challenges with challenges with the backbone, because we can't have like a dual regimen. You need to have oral combined with an injectable. You need to have something concrete and steady. The injection site reaction, pain, swelling, and nodules that do happen, but it's mitigable and then manageable. The problem with these resistances, these long-acting drugs, is people, if they don't come back for their follow-up, there is a chance that these drugs disappear of their system very slowly, and that gives them a chance for developing resistance. The other important thing is we need to also understand that India is a country with a lot of TB. So rifamycins and other drug inducers, there is a chance of a lot of drug interactions that happen. So that also makes it not suitable for all people. So the other thing that people also have a misnomer when they talk about long acting, people always think it is an injection. It doesn't necessarily have to be. We can always have oral tablets which are long acting, which can act for about, right now we have weekly oral tablets, but we might have something which is a little longer as well. And all of these regimens, it's very important to understand and remember that they have to have no hepatitis B. This is still an active area with many drugs in development, and we'll have to wait and see how what the future holds. It's still a developing area, and yep, with that, I would like to conclude my presentation, and thank you all for your patient listening. We can take questions at the end of the day. End of the sessions. And this is our team from YRG, and we have a good team, and I would like to thank my team because they help me do what I can do well. Thank you. Over to you, Dr. Rifa. I'll stop sharing my slides.
Thank you, Dr. Pradeep. Shekhar, am I okay to share my slides?
Yes, ma'am, you can share your slides.
All right, thanks, Dr. Shekhar. Thank you.
Yeah.
All right, I hope my slides are visible to everyone. So thank you so much for this opportunity to share about our experience of scaling up PrEP in the community and where we see opportunities to improve in operationalizing PrEP across India. So the operational framework to start off with, how we operate at YRG Care really is at the heart of everything we do is community engagement. And from there, sometimes we develop implementation research questions. And we know that every research question has two outcomes. Either it will give you a new research question, or it could give us some answers which we can then take back to the community and for all their efforts to help us find that question and possibly that answer. And sometimes when you have a new research question, we then sort of funnel it into a randomized clinical trial. And again, the answers that we get, we have to give it back to the community. So really at the heart of everything we do is community engagement. So today's discussion really is going to focus on how we sort of scaled up PrEP in the community. What was the process? What were the operational challenges? What were the clinical conundrums that we faced? How can we do better? As we're moving into the next era of injectables, as Dr. Pradeep already spoke about. And I hope, this is going to be a good interactive opportunity to, either learn from you or get to hear about your perspectives as well. So to start off with, I think oral PrEP is a formidable placeholder in the fight against HIV, because despite 3 decades of efforts, we are still unable to find a vaccine. There are obviously a lot of challenges around it, not particularly restricted only to circulating recombinant forms. There are a lot of other challenges as well that come up in vaccine development. But particularly in resource-constrained settings like ours, oral PrEP is proven to be a critical and effective prevention strategy. And as we observe high-income countries are transitioning now to newer injectables, it is even more important for us to see what were our mechanisms for scaling up oral PrEP. How do we fine-tune them to make sure that we can now offer injectables through the same routes, but do it better, right? So very quick recap on how oral PrEP works. I'm not going to go into the details of this because I think any AI tool can offer this to you. I want to focus more on the real life challenges. So I think just a very quick snapshot here is that PrEP basically creates a protective shield around the T cells and, basically preventing HIV from, integrating and replicating it. All right. So we just keep it simple to that. And the intake concepts are also fairly simple. We basically, we would say daily PrEP is basically taking PrEP once a day, right? And making sure that, there isn't a gap of more than 48 hours once people are on PrEP. And if there is a 48-hour gap, then we would likely advise them to be careful over the next 1 week while they're on PrEP, because there are studies that have shown that it takes at least 1 week of daily use of oral PrEP for the concentrations in the body to offer optimal protection against HIV. The other option is, of course, on-demand PrEP. And this is, essentially PrEP basically needs to be taken in a 2 to 24-hour window. And that's the first dose. And the second dose would be 24 hours after the first dose. And the third one would be after another 24 hours. But the practical challenge of this was, essentially when people are having a good time, no one wants to keep in mind, what the calculations are, when was the last dose. And there's a lot of panic around people who usually were not very organized about their pills. And it would then lead to a lot of panic testing. So we would, as much as possible, try to sort of encourage daily PrEP in those individuals who are not able to manage these situations. Of course, PrEP has to be personalized to a patient's requirements. So if we did have patients who were sort of the kind who did not have an exposure, very often, and they did have other medical conditions, then of course it made sense to sort of encourage on-demand oral PrEP. But having said that, whether it was daily PrEP or on-demand oral PrEP, the message was quite clear to them. It was basically that PrEP plus use of condoms is the ideal protection. We would make sure that the use of PrEP is not giving rise to other STIs. And it was made very clear to them that PrEP does not offer protection against other STIs, right? So I think there's overwhelming evidence now about the use of PrEP and how it can protect people in the absence of a vaccine. Perhaps the best option at the moment for protection from HIV. And as I mentioned earlier, that we would offer them basically two choices. One is tenofovir disoproxil fumarate with emtricitabine, or tenofovir alafenamide and tricitabine. So these were the two options that were given to individuals, and they could opt for the brand that they preferred, being based on their paying capacity. And of course, we would guide them on which was better, right? Because not many people can sort of interpret research findings well. This is mostly, we have a lot of very well informed patients, and I really encourage patients showing up with research articles saying, can you explain this to me? And I say, yes, sure. So there were concerns about loss of bone mineral density among people who are using TDF, and then sort of having to explain to them that it's only on prolonged use, and how what percentage of loss of bone mineral density are you seeing. Then there were individuals who had come to us saying that, will there be an impact on my on my renal function? Will there be a change in my glomerular filtration rate? So we do have to sort of explain to them about how GFR has other factors to consider. It includes your age, it includes your gender, it includes your lean body muscle mass, your protein intake. There's so many other factors that and we really had to counsel individuals on what is appropriate for them, right? Because while tenofovir alafenamide is a great drug, it also has its challenges, and so it's important to discuss that in view of the individual patient history and their concomitant medications. Now, how did we go about doing this? So the reason why I'm quoting the source as the NACO technical guidelines for 2020 is because YG Care was part of the consultation in writing up these guidelines, and we had great support from NACO in basically, implementing these. And what these guidelines essentially said that, we spoke about what exactly PrEP is. It's a daily pill that reduces HIV risk by over 90%. And who should be taking PrEP? Anyone who is at substantial risk for HIV infection. Now, substantial risk, the operational definition of substantial risk obviously varies. So I will go through that with you with the different patient profiles that we saw. And of course, we cannot be handing out PrEP to everyone unless they are eligible to it. So we had to ensure that people were eligible for PrEP. So they had to meet a certain eligibility criteria, right? And so the next step would be, to assess their risk and counsel them. And then, of course, you do a baseline health screening, which includes testing for HIV, hepatitis B and C, checking their renal function, making sure that we are screening them for STIs. And then, of course, they're given a 4-week prescription. And, in those 4 weeks, we get to learn a lot about the patient, and the patient gets to learn a lot about their social activities. They get to observe what is the frequency of, and the pattern in which they are interacting with individuals, because that will then determine whether they need to then continue on daily PrEP or on-demand PrEP. And of course, so before we started sort of prescribing this and including other providers to join us in this endeavor, we had a training sort of a module that was created for PrEP providers across India. This was done in partnership with Fenway Health, and I believe these modules are still available, and they basically speak about how people how to elicit sexual histories, especially in key populations who may not otherwise seek healthcare in mainstream hospitals. So this course is, it's a short course. It's for 2 to 2.5 hours. And at the end of the course, it's a free program, and people get a certificate, which basically says that you can, now go ahead and prescribe PrEP, and keeping in mind certain criteria, right? And so how did we go about doing this? I just want to speak a bit about that. But before that, what we need to understand is what is the need. So WHO estimates that 10 million people need to be on PrEP to meet the 2030 HIV prevention targets, right? But since 2017, there's evidence that states that just about 7,000 people have accessed PrEP in India, okay? Now, we leveraged funding from USAID, and we had an implementation partner called Safe Zindagi. And since 2020, we were able to reach 3,486 individuals who were screened who are status neutral individuals screened for STIs across 95 cities across India. Now, given the size of India, that's not a big number. I understand that's but still it's a humble beginning, and I think we have a long way to go. And what we noticed is that there was high uptake among possibly men who identify as men who have sex with men, and the transgender people. And it was not just the metro cities. It was even in tier 2 cities. We could see that there was willingness. Once there was awareness, there was willingness. People really wanted to engage in sort of prevention practices that could help them sort of alleviate the risk of HIV, right? So how did we go about implementing this? We basically had virtual clinics and cloud physicians to support our implementation partners in the field. And nationwide, this, just to remind everybody, we started implementation around the same time that the COVID restrictions were in place. So around 2020. So for the first 2 years, it was a big challenge, just trying to write the guidelines, getting them implemented, and it was around this time where teleconsultations were a big, were really catching on big with everyone. So we had individuals basically contact us for teleconsultations, and then we had peer triage in sexual health coordinators who would basically assess the needs, in the community. And once they were sort of triaged, they would be put in touch with the cloud clinicians, and about 70% of the patients were seen by us in Chennai, by other clinicians in Chennai. And once these individuals basically sort of they met the eligibility criteria to be on PrEP, we would then sort of prescribe them the medications, which could be couriered to them. People preferred to be anonymous. People preferred not to have our logos on their prescription boxes, and on their medication boxes, and that's fine, because I think Vyology Care has a long history of ensuring patient confidentiality as far as HIV care is concerned. So that's essentially how we were able to sort of meet this operational goal. And when it comes to screening for PrEP eligibility, the NACO-technical guidelines say that we would have to check for whether individuals were confirmed HIV negative using a rapid antibody testing mechanism following HCTS algorithm on the day of PrEP initiation, right? So we would be testing them again, regardless of when they were tested prior to this. At substantial risk of acquiring HIV, no contraindication to use any medication used for PrEP, and does not have a current or recent illness suggestive of acute HIV, along with the history of probable exposure for HIV. And finally, assessed as ready to adhere to PrEP and willing to attend follow-up evaluations, including repeated HIV testing and monitoring. Now, this sounds really good on paper, but I'm just going to reflect on the operational challenges of this issue. Is that it's very, very important to elicit history of sexual behavior and the details of the last exposure. So it's really good for us to recheck the HIV status just before we start PrEP. But what would often happen is people, would get in touch with us as soon as they've had an exposure. They would have tested themselves either the next day or the same day, because that's the kind of panic that sets in and people want to test themselves. But obviously, we would have to remind them about the timelines of how early HIV can show up on a test. And perhaps what they did need at that time was not PrEP, but post-exposure prophylaxis. We have had instances where patients have, initiated post-exposure prophylaxis on their own, and they also want to start PrEP. Again, just kind of anxiety and being ill-informed about what they need to do. And then, of course, we do have to consider, the second statement, which says at substantial risk for acquiring HIV infection. Now, very often when we look at, HIV risk, we are looking at sexual behavior risk or injecting behavior risk, right? We're very often looking at these risk factors. But something that came to our notice, especially during the pandemic, was, to consider the environment as a risk factor, even in case of sexually transmitted infections. Okay, we know, from our knowledge in whatever in public health is that when it comes to vector-borne diseases, environment can be a risk factor. I just want to reflect a little bit on how environment can be a risk factor for sexually transmitted infections. Is that sometimes the patients who come to us, they are living with an abuser. They may be individuals who do not have the agency to, sort of negotiate the use of a condom. There may be individuals who are perhaps in difficult occupations wherein they're expected to do something that is not a part of their job description. And so these are individuals who definitely need our sort of non-judgmental support and making sure that they have access to PrEP. And the other bit which says that we need to assess if people do not have any contraindications or use of any medication. So here I just want to speak about the drug interactions with alternative systems of medicine. So usually when someone comes to us and they want to start ART or PrEP, we would obviously check the Liverpool tracker and see if there's any sort of drug interaction. Now fortunately for us, we don't see any sort of issues with most oral hypoglycemics or antihypertensives or people who take anxiolytics or these kind of drugs. But there is considerable number of patients who do take supplements. They may take herbal supplements, they may take Ayurvedic supplements, and I think that there is an opportunity there for us to explore what those interactions are, right? Some of them are definitely under the guidance of an Ayurvedic practitioner, which is good. But if there are people who are taking it over the counter or just ordering it online with no guidance of any other practitioner, then there is no way for us to know what that could lead to, right? And many very often people do show up later on with like issues of any kind of drug induced liver injury, and we may not be able to sort of identify what is the drug that actually caused this. So I think we do need to start looking at that now, looking at people using different supplements and how do those interact with the drugs that are in this system, right? So reflecting on the diverse groups of sexual minorities that we saw taking this up, we saw majority were cisgender males, both with homosexual and bisexual preferences. And we saw 21% transgender people who were sort of keen on taking up PrEP. And it was, as you can see, younger and younger people taking up PrEP. The median age was 28.5, but we did see people as young as 17 trying to access PrEP. Of course, there are certain financial barriers that prevent them from taking on and staying on PrEP. So that's another discussion that we need to have. And coming to specific patient profiles that we did notice with looking at serodifferent couples. So the guidelines say that, basically HIV, if there's a serodifferent couple wherein one is HIV positive and the other is HIV negative, the HIV seropositive partner's viral suppression, if it is uncertain or tenuous, then the negative partner should be on PrEP. Now, the operational definition of uncertain or tenuous is again something that we struggled with a bit because of the way that the viral load reports are documented in the public sector and the private sector. But we're very grateful for the support that we have from ART centers across the country, because if there was even the slightest doubt that we had about what assay was used when they say titer not detected, we would want to know how low is the titer, or if there's any other information that we need before we sort of get the family onto any prevention strategy. We've always received good support from ART officers across the country. And the next bit is that HIV seronegative partner we need to check if they have other sexual risk factors for HIV, such as sexual contacts outside of the serodifferent relationship. So when it comes to homosexual couples, this is a difficult subject to broach because it may not be viable for them to sort of speak about other partners, but it's an important risk factor in that situation. So for the purpose of the consultation, we would just assume that this is an open relationship, and we would basically want to make sure that this partner is safe, So that's why they need PrEP, assuming they have other contacts. And the HIV negative seropartner, we need to check if they have any drug use risk factors for HIV. So we would sort of request information for them about any sort of use of recreational drug use, especially with injectables. And, that's again a very difficult discussion to have around use of injectables and recreational drugs. Now, where we see research gaps is while we are very grateful to gynecologists and obstetricians and general practitioners who refer high risk individuals to us when they sort of sense that there's a need for PrEP here. But we still feel that there is some amount of hesitancy in acceptability of PrEP. And I think some of it sort of stems from the fact that, we're essentially using a component of ART for PrEP. So I've received calls from, a colleague saying, is it really necessary? Can they not sort of adhere to behavioral protection measures? And I think one of the most difficult things to change is human behavior, right? So while we could say from a ethical or a moral standpoint that yes, perhaps this could work, but I think we have to think about it objectively, scientifically, that there is a pharmacological intervention that is available which can help these individuals. So they do have the right to know about how they can use it, right? So especially in India, I do want to speak about these hidden figures. We spoke about serodifferent couples. Now, the composition of a serodifferent couple looks very different in many countries, not just in India. So we just want to reflect a bit on that as well. So we have homosexual couples, we have heterosexual couples, but we also have a lot of bisexual couples. Okay, it will be very, very. It's not very uncommon for us to have a discussion, with the patient where they start off a discussion by talking about why they need PrEP, and how they have a male partner, and once we have a rapport with them, they gradually disclose that they also have a wife, they have children, they have families. And I think it's important to have a discussion with them about screening everyone, making sure that the entire family is safe. So these are, again, challenging discussions to have, but very, very pertinent. So this is all evidence from the work that we've done, which basically shows us that there is, the prevalence of undisclosed MSM and disclosed MSM, as you can see, in different age groups, and the spouses of those disclosed MSM, where what is the HIV prevalence amongst these? If you can see, this is quite a telling graph. And then, of course, looking at their engagement with the HIV care cascade. So if you look at among those who are HIV infected, if you can see the proportion of spouses of disclosed MSM is slightly lower in most of the situations, whether it's awareness of HIV status. But once they're aware, their linkage is better, their pre-ART retention is better. And then, of course, if you can see, it sort of goes hand in hand, where you can see the disclosed MSM and the spouses of the disclosed MSM tend to do better than undisclosed MSM. MSM being men who have sex with men, right? So keeping in mind this, evidence, we encourage people to sort of have the discussion which makes their family safe, and making sure that all of them have the necessary precautions. The next sort of group that we looked at is transgender people. What we observed is that there is high willingness but lower awareness. But once people were aware, they did speak to us about the fear of accessing PrEP due to the stigma that they have in accessing healthcare from mainstream hospitals. And they do have some concerns over concurrent use of gender affirming hormone therapy. But fortunately, there was initially something called as Mitra Clinic, which was India's first transgender clinic that was set up in Hyderabad, and we had another one in Lucknow after that. But I'm sure, as many of you are aware, following the USAID funding cuts, these were shut. And as I've always believed that India finds a way out of most challenges, and so we did again. And so the Tata trusts have now come forward to support these clinics, and So these are now called as sub-rung clinics, and they're basically, essentially run by transgender people, operating as frontline healthcare workers in these clinics. So we're hoping to get back to offering this to the transgender people. And the reason why this is important is that from our data, what we could see is that the PrEP discontinuation was highest amongst the vulnerable groups, highest amongst the transgender individuals, and of course the younger users. And younger users, we understand it's possibly due to financial implications around using PrEP. And then, of course, I'll speak a bit about the geographical distribution of what we saw in a bit. And so before we get into that, I just want to take a moment to speak about something that we genuinely were not, I think, as prepared for. But now we are better prepared in understanding this. This is again from evidence of work that was done at YGK, which is basically prevalence and impact of childhood sexual abuse on HIV risk behaviors among men who have sex with men in India. So elements of, basically individuals who had experienced this unfortunate childhood sexual abuse were more likely to then go on to, engage in certain practices and were at higher risk of developing HIV, in addition to other things like depression, right? So based on this evidence, now we knew that the calls that we were going to get were going to be uncomfortable about people who may be in difficult situations. So we had to make sure that they were safe. Firstly, we need to make sure that they're safe, they had access to the right legal aid. We wanted to make sure that, after these things were in place, we would then sort of get them on to PrEP, right? So, especially when it comes to adolescent and young adults, what we've observed is that HIV and hepatitis B service delivery models, they mainly focus on adult and key populations, youth and children. But disease prevalence and service uptake amongst adolescents is poorly characterized in India. And if you see, these are estimates from UNICEF and WHO. I'm sorry if it's not very clear, but what it really says here is that there is literally not enough data, no data on adolescents when it comes to access in healthcare service use, HPV vaccine uptake, and basically comprehensive school health services, and schools offering HIV and sexual education, basically. So it's not possible that for a country like India that this isn't happening. What I'm saying is that we don't have, organized data around this to offer better care to this group, right? So what we have done at YG Care now is that we're, basically hoping to operationalize this initiative, which is called a Spark Clinic. We're basically looking at, offering services to high-risk adolescents and, adolescents living with, HIV. So there are different components to it, looking at mental health and sexual and reproductive health and clinical services. We're trying to integrate this into our existing system, but with the focus on the fact that we need to basically gather better data around the uptake of services amongst adolescents and young adults. The next bit is looking at men who have sex with men. The perception among men who have sex with men has evolved by leaps and bounds from basically this is again uptake of PrEP, so social stigma, initially social stigma, but then gradually now high willingness. In some pockets, still low awareness, but once they're aware, they're definitely more willing to engage with PrEP. And we do observe certain social disparities among smartphone users. That is, there are certain people who are on different apps where, they mention of use of PrEP for them is like a badge of honor. So they say, because I'm on PrEP, you should interact with me. Whereas people who are not as socially active, they may not really know what PrEP is or, why they need to use it. But overall, amongst this particular group, the preference is intermittent dosing. They prefer on-demand PrEP rather than daily PrEP, which again sort of makes the case for long-acting injectables stronger. Subsidized, everyone prefers subsidized medication, I'm sure, and they would prefer to take it from the public sector again. Another important aspect to consider is aging MSM and their partners, because as I mentioned that, we would try as much as possible to personalize, PrEP use to the user. And as many of you know, that people living with HIV are living much longer now, and so their partners are also, potentially aging partners. So keeping that in mind, we do need to make sure that we offer the right PrEP to them, right? Not in any way jeopardizing their health any further. So, what were the research and implementation gaps that we found? Again, awareness among general practitioners. Many people, sort of said we went to our GP, but they were hesitant to prescribe PrEP to us because they thought we were prescribing them ART. We were asking for ART again. And again, like I said, willingness among healthcare providers is key. And the use of supplements and anabolic steroid injectables among MSM is again a major issue, because I'm sure many of you know the Indian wellness industry is booming. It's like projected to be at $70 billion by next year. So what we're looking at is people basically using a lot of supplements. They're very conscious of the way they look, and so we really don't know what are the implications of the interactions of PrEP with these supplements that we don't know much about, right? So that's again something for us to be mindful about and watch out for. Another important aspect that I would urge everyone to consider is, looking at PrEP and from the travel medicine perspective, because we went through a lot of travel, medicine guidelines, and apart from perhaps Canada and maybe a few other handful other high-income countries, not many of them mention or spoke about PrEP for protection of HIV, and it is well documented that individuals' behavior, sexual risk behavior changes when they travel, when they're on a holiday. And so we do have to have discussions around this with people. Many people would come to us, say, we need short-term prescription. Only when I'm traveling, I'm likely to interact with other people. Or if there are people who are immigrants, who are students, who want long-term prescriptions because they don't know what a new healthcare system looks like, then again, that's something that we can help them with. We can facilitate that. But it's very, very unfortunate and important to remember that there are still 50 countries which have restriction entries for people with HIV, and travelers in these countries can even be deported if they are diagnosed with HIV. So, as I mentioned earlier in one of my earlier slides, that we would always encourage people to say that PrEP and use of condom is still the best way to protect themselves from HIV. But now would layer on another fact, that is HIV self-testing. The self-testing kits are absolutely like a game changer. From an epidemiologist point of view, yes, it sort of disrupts the denominator, because we don't know who are these people and if they've been documented or not as people with HIV, because these reports, these self-testing results just go unreported, right? So, but in the interest of the patient's health, I think they are really a game changer. The other opportunity that PrEP gave us was to discuss immunization among diverse, groups, and especially about hepatitis B and human papillomavirus. So the WHO and UNICEF estimates that hepatitis B vaccine coverage of 0 dose in India is concerningly low. All right, and there is some evidence from on this from different parts of the country. In a study that was done by YRG Care, we actually observed that the vaccination serostatus was less than 10% among key populations, such as people who inject drugs and men who have sex with men. So, given this background, we made it a point that we would look for protective titers amongst individuals before we initiated them on PrEP. Also checking on people who, who are once initiated on PrEP. We also want to make sure that these are not people who have like chronic hepatitis B and then they want to be on-demand PrEP. That would spell disaster for them, right? The other important, discussion is to have about human papilloma virus, that is the HPV vaccine uptake. I think with India's manufacturing capacity, we now have brilliant generic vaccinations that can be used, and to have that discussion around, vaccination even among adults. Many people are now reaching out to us about vaccinating adolescents and young adults, but even older adults can access HPV vaccination, where up to the age of 40, we definitely they can be vaccinated if they are considered to be high risk individuals. And so the bridging this research and implementation gap, what we would do is, specifically screen for them while determining the PrEP eligibility, look for their vaccination status, follow this up in both cases. And the awareness among healthcare providers again needs to increase, because we speak about HPV vaccines. The first thought is, of course, women need to be vaccinated, but it's not just looking at cervical cancer. We are looking at anal cancers. We are looking at nasopharyngeal and oral and throat cancer. So thinking about all of that, HPV really is something that can alter a lot of things for people with these risk factors. So what have we done? At the Sunti Solomon Center, there's now an integrated immunization clinic where we are focusing specifically on scaling up, testing and making sure people have access to these vaccines at a subsidized rate if possible. Now, coming to the other issue was screening for STIs. So there is there is evidence, I agree, that people taking on PrEP sort of become complacent with use of condoms, and that can give rise to STIs. All right. Now, overall, what we found is that even before, this is pre-PrEP, individuals pre-PrEP had a very high prevalence of syphilis. This is either past or current infection, right? So we wanted to make sure that these people are getting tested at regular intervals. The other issue with syphilis is, of course, there's a lot of confusion around analyzing or interpreting the serological results. So it's a slow infection to sort of leave the body, so people keep panic testing themselves, and if they don't feel like the titer is reducing fast enough for them, then they keep self-medicating, they keep taking doxycycline, because for them it's available over the counter, and not many of them know that they need to be treated as per the age of infection and not really based on the titer. So just because they have a titer of 1 is to say 16 or whatever, it doesn't mean that they always need to take 3 doses. It depends upon their sexual history, it depends upon their treatment history. So those are discussions that we need to have with individuals. And this is particularly important for us because I spoke about the composition of different couples in India, which can really range from being from homosexual, heterosexual, and bisexual. So just thinking of this transmitting all the way to partners of men MSM who haven't disclosed their status is really a challenge. While in India we have very good, sort of setup for antenatal testing, by that time it is quite late, right? It shouldn't be at the time where women are coming for antenatal testing and that's when they find out that they have syphilis. So again, this is something we want to characterize. We want to know better how we're doing this. So in our next step right now, what we're doing is we've partnered with an institution to sort of understand the genomic epidemiology of Treponema pallidum in India, to try to see if we have anything different in our country. Because really this challenge is something that can amplify HIV risk, because on the one hand we are seeing PrEP intake, the uptake sort of lower, and on the other hand we're also seeing this risk of syphilis increasing even among people who are not on PrEP. So I think this is again in a space that we need to watch out for, the absence of a vaccine for Treponema pallidum. While we hope that our findings from the genomic epidemiology of Treponema pallidum can inform vaccine development, that's still a long way to go. The other important bit is the erratic and inconsistent use of doxypep. I mean, people have no idea what dosage they need to use, and they're just abusing doxycycline. And I'm genuinely concerned that we may lose the drug if it continues the way it is going, right? So these factors highlight the critical need for us to step up sexual health awareness and integrate these services, especially among younger sexual minorities, especially in tier 2 cities. And so we want to keep it simple. We want to accelerate this, basically peer-led support systems to improve PrEP adherence. We ideally want to integrate STI screening and treatment directly within HIV prevention and PrEP service delivery programs. And we do want to focus on certain high-risk groups, especially in tier 2 cities, right? So finally, this is my, one of my last slides. So basically, I think Dr. Pradeep has spoken in detail about lenacapavir. Essentially, for PrEP, it's going to be twice yearly injections, and that should take care of a lot of, sort of risk from HIV. There's been recently a partnership with, United Clinton Health Access, Wits University, and Dr. Reddy's laboratory, where through this they're hoping to bring down the cost of lenacapavir to about $40, and at scale, at larger volumes, it can come down to as low as $25. And the hope is that this can be rolled out to 120 countries by 2027. And in the interim, Gilead is supposed to offer about 2 million doses. But now remember one of the first slides that I mentioned, that WHO estimated that 10 million people need to be on PrEP for us to meet HIV prevention targets. So we're definitely going to fall short of that, right? So the final question really is that, India is the world's pharmacy. It is the global pharmacy. But the question is, can we scale up domestic use to make sure that we have enough for, the Indian citizens, and hopefully, we can meet the prevention targets that we've set out. Thank you. That's it from me. If you have any questions, I'd be happy to answer them.
Dr. Sridevi.
Yeah. I'm just opening the chat only. So there are few questions. So Dr. Pradeep, one question is from Dr. Anand Rao. If forgetfulness is an issue, would it be worse or better with a weekly pill or a daily pill?
So if forgetfulness is an issue, okay, that's like commonly people forget, and I'm not sure. One is they forget. One, they're not sure if they even took the medicine on that day. Okay, two things that happen. Okay, so with weekly, the problem. So the thing is, it all depends on how your packs are made. Okay, you can have blister packs which are made for the month. Okay, so if you have a blister pack that is made for a month, you have 4 tablets that are kept for a month. So you won't have confusion. If you look at your blister pack, you will know if you have taken your medicine for that day, or let's say, for example, on a Wednesday, if you decide to take your medicine on a Sunday, and you look at your blister pack, you will know that, okay, this Sunday, the first Sunday I took it, and this Sunday is yet to be taken. So you won't get confused. The problem with having too many medication on a daily pill is people don't manually pill counts, and only way you know if you've taken your medicine for that day is like to manually pill count and check it out. So from an adherence perspective, it will be easier to do it on a weekly basis. Okay, slightly superior to like trying to check it out daily, and it's easier to check if you taken it for the day. Whether reminding it is like a thing, you have apps and you have phones to give you reminders, so you can utilize that, or you can use the technology to help better remind you to take the medications.
Yeah, right, sir. The next question is from Dr. Par. For a person on daily PrEP, how long can we give the drug? Dr. Rifa, would you like to answer?
Sure. So as per the NACO guidelines, someone who's just initiating PrEP, we would give them for 4 weeks, right? And then they would have to be tested again. We basically do a creatinine clearance and look for their serum creatinine, those things, and then reassess their risk factor.
Okay.
Then again, they can.
And
but
there
once
is one more question from Dr.
Up to 3 months, but after 3 months, they
Am
would
I
need
audible?
Yeah, you're audible. Yeah.
Now you're not audible if you're trying to talk.
Yeah. Am I audible now?
Now
Yes,
you're
you
back.
are. Yeah.
Yeah, I have some bandwidth issue at my end. So there is one more question from Dr. Par. In a discordant couple, when they are trying for pregnancy,
We lost you again. So maybe Dr. Rifa, would you like to just look at if Dr. Is having some issues with that thing, can you just go ahead and look for questions on the chat and then just answer
Yeah.
it? That'll be, yeah.
All
yeah,
right. So the question is, in a discordant couple, when they are trying for a pregnancy, how many days before and after should we give PrEP? So this is a very good question because we get this quite often. We need to work very closely with the gynecologist or the obstetrician that they're working with, and ideally, what we would say is we would follow the same sort of pattern and giving them PrEP for four weeks and just seeing how it how they get on with it, because it's not a given that every interaction is going to lead to conception, right? So it may be that they may need many more sexual interactions for them to actually conceive. So we let them get on to PrEP. They go ahead, once they've conceived, they let us know, and then they inform their obstetrician, and then they can stop PrEP. So we make sure that they keep the obstetrician or the gynecologist informed about this, and then they can stop PrEP, because these drugs are not going to harm in any way, any kind of conception that's taken place. It's not going to harm the unborn child or the fetus. So
But also please remember, it's not a fertility drug. It doesn't make you,
yeah.
it's not a drug
It's-
to make you pregnant. So please,
so we
yeah,
do stress on that a bit, quite a bit, and say just a reminder that this is not in any way going to hasten the process, or sort of get in the way of fertility. If they have a genuine fertility issue, then there are fertility specialists for it. That's a whole separate discussion to be had. This is only to protect them from HIV.
yeah.
right, doctor. There is question from Sansi for Dr. Rifa. What are the problems faced with doxyprep? Pep?
Thank you. So the main
Hmm.
issue is, so this whole doxypep guideline came from Florida. Basically, they said that, it was done in that population, and then there were modeling estimates that were used, and then from there on, that information has just spread like wildfire amongst key populations. So essentially, doxypep requires you to take 200 milligrams of doxycycline within the first 72 hours of intake. But this cannot be a way of life. You cannot be popping in doxycycline throughout the year, every 72 hours, to make sure that you're safe, right? So many people usually end up taking just 100 milligrams, or they don't know when to take it, or they're taking 100 milligrams for 1 week. So essentially, people are just doing whatever they feel like with doxycycline, right? So we usually advise them to say, if it would be much better if you get yourself tested more frequently, so you know exactly what you're need to be treated for, rather than blindly just taking doxycycline.
Right, ma'am. So there is question from Anand Rao. If U is equal to U, what is the need for PrEP in serodiscordant couples wanting to conceive?
100% agree. That's so there's a difference between being rational and, I think, being reasonable. Now, we know that, the guidelines say that U is equal to U, is undetectable is untransmissible. And we try a lot to explain this to different couples. Okay. But unfortunately, there is like this hesitancy in people saying that I don't trust the fact that, there's a trust issue there, because very often they would have just found out that their partner is, retropositive, and so they don't believe the test results, they don't believe their partner, but they still want to have a child with this partner. So they then sort of decide that, they would rather opt for an IVF, wherein, which can be very, very expensive. So sometimes the midway discussion is, okay, we can try PrEP because this seems like an alternative. The other issue is there are some patients who come to us and talk to us about viral blips, and some of them also talk about issues about, what if my partner is not adherent to their medication? Yes, their reports are at the moment they're saying that they're undetectable, but what is it not? there are many serodifferent couples who have a very good understanding of each other's health and very good understanding of the science, and they understand that U is equal to U, and in those cases they don't need PrEP. But then there are certain other issues, where they're not planning for conception, but they do want to sort of engage in certain practices. And I think this is a very, very complex issue, because once there's a breach in trust, I think, in partners, then there is a chance of them having other sexual encounters. And I think for that sake, they do get onto PrEP. I hope that sort of makes sense.
Yes, ma'am. The next question is, when would be ideal to stop PrEP after unknown sexual contact and testing negative at 12 months?
So I think that question, you're saying, when would it be ideal to stop PrEP after unknown sexual contact and testing negative at 12 months?
12 months.
So
You just explain how, when you have to stop. I don't think you need to continue for 12 months. Just
right.
explain.
Yeah.
Yeah.
Duration.
So basically, what the WHO guidelines state is that one would have to take PrEP continuously for 7 days after the last exposure, particularly if it is like anal intercourse. So, ideally you would want that 1 week of exposure after, any sexual contact. Earlier, the guidelines said 4 weeks, but the most recent WHO guidelines say 1 week, provided the individual has been on PrEP prior to, this exposure as well. But if you have not been on PrEP and you've had a contact, then PrEP is not for you. You should be on post-exposure prophylaxis to be started as soon as possible.
Yeah.
Right.
Now, the other thing is you have your on-demand PrEP, which is also telling you 211, and on-demand PrEP is only right now approved for men who have sex with men. So in that group, they do recommend stopping PrEP in 48 hours. So but for all reasons, to be on the safer side, like Dr. Rifa said, 1 week would be the best time to stop PrEP.
Yes,
Right.
sir.
So the last question, I think, what about persons with resistance virus? Yeah. What about the persons if they have sex with resistant virus infected person? How is PrEP going to help if they don't use condom, Dr. Rifa?
I mean, I think the question here is alluding to the fact that if they have resistance, and probably their viral load is going to be high. Have I understood that right?
So I think the question is, what if you have a baseline virus which is resistant? So that's one of the reasons that PrEP can fail. Okay, so if you look at PrEP, reasons for PrEP to fail, one is your adherence issues where you don't take your medications. And the other reason is you have a virus which is resistant. So you're right now, the drugs that we are doing right now in India is tenofovir emtricitabine or tenofovir lamivudine in both TAF or TDF. And those drugs are they are NRTIs, and there is a likelihood chance that sometimes you have resistance virus that can come in, right? So if that comes and if the drug is not effective, then there is a high likelihood chance of failure. That's one of the reasons why newer drugs, especially lenacapavir, which has shown 100% effectiveness as PrEP, because we have not had that with anything else. You have another molecule developed by Merck called, it still does not have a name. It's MK8527. It's an NRTTI, the reverse transcriptase translocation inhibitor, and that is shown to be 100% protection in animal studies, irrespective of resistant virus or anything. And so I guess we have these challenges with tenofovir and drugs with resistant viruses. Yes.
I think just to add to that, that's why we always stress that, it's PrEP on its own is not good enough. You still have to use other protection measures as well. But
there is one more question on from Anand Rao. Are there studies on the incidence of pre-treatment drug resistance? Unless we have that information, we may not be able to answer Dr. Swami's question.
So you're talking about resistance in PrEP,
yeah.
right?
Yeah. You want to go ahead or you want me to answer that?
Yeah, go ahead.
Yeah, no, there are cases and case reports that have been published on people who fail prep. Okay, there have been case reports where I remember one case report published by uh, Dr. Paul Sachs. Is a very famous researcher, and he published maybe 5 years back somebody who's been on regular prep, and then he developed a virus which was pan resistant to all. He picked up a virus. I mean, he had a breakthrough infection, and when they analyzed and did a genotyping, and they found that the virus that he had picked up had resistance to NRTI, NNRTIs, PIs, all three classes at that point of time. Okay, so there are some reports, but you don't have large case studies or large cohort-based studies, but you do have results and reports. And even among people who are failing on cabotegravir, PrEP, failing on cabotegravir, there are chances of developing INSTI resistance, either because of, we do not know whether it is secondary to the baseline virus that comes in, whether the virus is mutated, or if the virus that has come in secondary to sub-threshold levels of cabotegravir or something has developed resistance to cabotegravir. But there have been reports that have shown that there are resistances that do circulate. Yes.
Yes, sir. Thank you very much. I guess there are not questions available right now. We have answered all the questions. Yeah. How
So there
frequently
is a
should someone on PrEP get tested? Sensi. How frequently should someone on PrEP get tested?
How frequently they should get tested?
Get tested.
At least every 3 months, and depends upon their sexual behavior. And that's why they need to speak to a clinician, because we'll be able to guide them on how often they need to get tested. But definitely at least once in 3 months. I think there's one question about
Does PrEP have more side effects, and regular ART has more side effects?
I mean, from the evidence that we have, there's nothing to suggest that PrEP has more side effects. Like I said, it needs to be personalized to the individual. You have to take into consideration, the individual's, his risk of developing certain complications. We need to look at what are their concomitant medications. So it cannot be a generalized sort of statement and say, but definitely PrEP does not have more side effects than ART.
So the other common simple sense is that you are giving PrEP to somebody who is healthy, who does not have comorbidities. And then on the other hand, you're giving ARTs to somebody who is already sick with a lot of other complications and comorbidities and other things that come with it. So they, on paper, you generally tend to have slightly more side effects with, or, it's not always have to happen, but you always watch out, right? So depending on the drugs that you are exposed to. But I think with PrEP, it's quite safe. I don't think side effects are a major concern. We monitor them closely for, if there are developing any renal issues. We don't routinely check for bone mineral density unless somebody is complaining. The other thing that happens with TAF is alteration in lipid profiles. So that's something that you need to be watchful and mindful of. It's mostly the kind of drug that you're going to be giving them, and then you need to be careful. Anybody can develop those side effects, but it's not higher than people who are on regular ART.
It's just not just about what you're prescribing, it's who you're prescribing to, right?
Correct.
So that's very important to keep in mind.
Right. From Sansi, where is the PrEP course for healthcare providers you mentioned available?
Sure, it's available on Fenway Health. I can share the link with Shekhar perhaps, and he can, share it with the others who've joined the link today. Is that okay, Shekhar? Yeah.
Yes, sure.
Yes, ma'am.
So I think there are no more questions. So there is a compliment from Dr. K.S. Satish from Bangalore about excellent talk from both the speaker to, and from behalf of MQR, I would like to thank both the speakers, Dr. Pradeep and Dr. Rifa, for sharing your valuable insights on long-acting injectables as well as oral PrEP in today's sessions. And definitely, like, it will help us for improving the current oral PrEP strategies, as well as transitioning from the oral PrEP into the injectable PrEP, as well as transition into the long-acting injectable treatment options. Also, I'd like to thank all the delegates, participants for contributing to these important discussions. And thank you very much all. Happy weekend.
Yeah. Thank you. Have a good weekend, all of you. Thank you. Bye-bye.
Everyone, thank you.
Thank you, sir.
Thank you, both of
Dr.
you. It's a wonderful session.
Thank you.
Thank you.
Thank you.
Thank you.